I hope there's a mixture in my audience of surgeons, cardiologists, I think pathologists, as well as technicians as well. So I hope I'm not insulting anyone with what my definitions will be of infarction, etc. But I said to clarify and make this quite simple, my talk is pathologically orientated. I'm a pathologist myself. I let the clinician deal with the clinical problems. But what we taught, myocardial infarction. Dr. Mann already discussed the actual vascular lesions leading to infarction, most common cause of which thrombosis overlying an atherosclerotic plaque. Now, infarction itself is really defined as necrosis or death of the tissue. As you know, myocardium does not regenerate. So if there is an insult to the myocardium resulting in death, necrosis, and it's due to cessation or interruption of the blood supply, it's the important factor. Infarction itself comes from the Latin infarcere, stuffed with blood, often associated with reperfusion after the cessation of the blood supply and restoration of the blood supply. Now, as Professor Anderson already displayed to you, and this is a slide I got from Dr. Yen Ho, where the coronary artery circulation is beautifully demonstrated. You can see here the right coronary, which in this case is quite small. Often it's much larger, but in this specimen it's small, emphasizing the variation among individuals of the actual coronary artery anatomy itself. The right supplies the right side of the heart and the right margin here. So the interference with its blood supply usually results in infarct because the right is dominant, as already discussed in detail this morning, in posterior infarct, a regional distribution of the death of the myocardium. In contrast, you see the left coronary artery here with a short main stem, and the left anterior descending artery, a large artery. And this is important because the origin of the AD is the most common site of thrombotic occlusion of the vessel in the majority of cases. And here, branching off, is the circumflex, which is the least common site of occlusive thrombosis in series that have been shown. Now, here thrombosis results in regional distribution of the infarction in the anterior aspect of the left ventricle, an anterior interventricular septum, whereas in the circumflex you'd have a more lateral infarct. Now, it's important to actually find what type of infarction we're dealing with and distribution and extent of the infarction. So I emphasized already that the coronary artery circulation is regional in distribution, and if it ceases, blood flow ceases with it, the infarction is regional in distribution as well. And these infarctions are usually transmural. You have got occlusion of the main coronary vessel itself, so it involves the full thickness of the wall. On occasion, when the interruption of blood supply is transient, you may get a non-transmural infarct. And this usually involves the subendocardial zone of that region. At times one may not see anything macroscopically, and you can see focal microscopic infarction. In other words, you need histology itself to confirm that there's been damage to the myocardium. In contradistinction to specific regional infarcts, you've got diffuse infarcts involving the whole of the myocardium. Particularly, I'm dealing with mainly left ventricle. Right ventricular infarcts are quite rare. And the diffuse infarcts are mainly in a subendocardial distribution. And why is this? Because logically it's further from the blood supply, the epicardial blood supply. And also in addition, we'll make microscopic infarcts as well throughout the whole of the left ventricle, not just in subendocardial but transmural as well. So again, histology may be required to actually find these infarcts. Now, as already beautifully demonstrated, the major cause of infarction is thrombosis overlying atherosclerotic plaque in 99% cases. And you have atheroma with thrombosis, which may be occlusive or mural. On occasion, you make thrombosis which are embolic, let's say from a case of subacute bacterial endocarditis, or in a patient who is hypercoagulability state with in situ thrombosis. Rarely you may get a normal coronary artery in which gets spasm, transient spasm, which cuts off the blood supply to that vessel and that part of the heart. And one may find a normal coronary circulation in presence of an area of regional infarction. And finally, extremely rare causes of destruction of blood supply would a dissection. You can get idiopathic dissections or interruptions of the media of coronary arteries. I have seen one case myself, quite a rare cause. So it's important when one sees an area of infarction to look for the thrombotic occlusion in the coronary artery. Now, what do we pathologists see if we get a case of query myocardial infarct? Well, the early changes up here, 15 hours. Before that, you rarely will see any macroscopic changes. The problem is the early changes are quite subtle. Edema and pallor. And I submit I myself have problems in, let's say, seeing an edema to slightly pale myocardium, contrasting with the left of the myocardium. So it can be quite a problem for pathologists to decide definitively that an area is infarcted macroscopically, particularly in early stages, under 24 hours. Within 36 hours, the change becomes more obvious and easier. You get an area of yellow caused as necrosis of the myocardium. It becomes yellow instead of the normal muscular red. And you get a hemorrhagic rim to this as well as an inflammatory reaction around, and also opening up of the capillaries around the area of infarction. Then it becomes white as there is reorganization, granulation tissue, white with a hemorrhagic rim at 7 days, and fibrous tissue with thinning of myocardium because it's been replaced by fibrous tissue starts at 7 to 21 days, and a full scar will develop between 3 to 6 months. It is a general outline of the timing of infarcts. The problem in man is infarction is just one single event. Quite often there may be multiple infarcts of different ages in the one individual patient. Now here, hopefully I'll be able to show an example of an acute infarct. I'll try and lighten it up. Yes. This one is here about 4 days old, and it's in the anterior wall of the left ventricle. You will see the wall is slightly thin even at this stage. You see the necrotic area. It's transmural, involving the full thickness of the wall. You see a yellow necrotic center, and around, I think well demonstrated, is the hemorrhagic border to this, where there is actual opening up of capillaries to hypoxia, and there is also reperfusion of the more viable areas at the periphery. So a classical appearance of an infarct which is several days old. Now, as I mentioned to you, from our pathology point of view, it can be difficult to decide, is there an infarct present or not? And really to help us, we've got both microscopic and we've all got macroscopic techniques which we can apply. And the first is the hematopoietin basic fuscin picric acid stain, HBFP for short. Now it says here that the dead remains yellow and the viable red, but it's really the other way around. What happens is that basic fuscin is first applied. With the death of myocytes, the myofibrils tangle together and attain the basic fuscin. And this can be seen with the contraction band of necrosis. You get red staining, right? Whereas if there is viable myocardium, application of picric acid results in lysis out of the basic fuscin, but the dead myocytes retain the basic fuscin. Macroscopically, we use the nitro-BT method, and what you do is get a transverse section of a fresh myocardium, and one applies this nitrotetrazolium blue, and what it relies on is the actual destruction of the dehydrogenases. When there is death of a myocyte, enzymes leach out or destroyed. So you lack dehydrogenases in that area of the myocardium which is infarcted. And as a result, you cannot reduce the nitro-BT to a dark blue formazan, which viable myocardium can, because it's got dehydrogenase within it. So what you result is that viable myocardium is blue in colour because it reduces down to the blue formazan, whereas the dead is contrast very pale because it lacks the enzyme, its dead area. It's a very good method to actually delineate for you the extent of infarction. By naked eye can at times be difficult to judge how extensive it is. And I'll show you examples of these. Now here again is the nitro-BT. What you see is the right ventricle here, viable blue. Here is the anterior wall of the left ventricle. You can see here a transmural area of infarction which extends onto the lateral wall and also into most of the interventricular septum, with even posterior band going almost into the posterior wall, delineating, I think, very well the extent of acute infarction. So this is an example of a regional infarct, the anterior mainly. Here there was thrombosis in the left anterior descending coronary artery. And here is an example by contrast, the more diffuse subendocardial infarction. Again, the pale zone not staining blue, including papillary muscles and a thin band of subendocardium. These diffuse subendocardial infarcts are more likely to occur in a setting of where you have three-vessel disease of severe stenosis. You may not need thrombosis in these cases. It's often in elderly individuals, female predominance, and it can be associated with episodes of hypotension that can occur in these patients if they've got bleeding episodes, if they've got arrhythmias, if they've got anemia, or if there is an increase in oxygen demand with extensive exercise, for example. So one may not need a thrombotic lesion for this to occur. Now here's an example of a healed infarct. Because it's nitrotetrazolium blue, the viable myocardium stains blue, but as well as an acute infarct staining, or not staining I should say, fibrous tissue is also pale. This is an old healed infarct, 3 to 6 months after the initial event. You will see the wall is attenuated, quite thin, and you can see the fibrous tissue which has replaced the full thickness of the wall, with expansion of that wall as well. Now here, I think I'll darken one down. Yes, just to show the toxin picric acid technique, and to show here that you just see, I think, in slightly black and white more than pink, I think, in contrast. But here are the myocytes that are dead. They're dark and black here, they're red, retaining basic fuscin, whereas the viable myocardium around is yellow. So here, a histological microscopic technique of detecting dead myocytes. Now the microscopic changes we may see, because sometimes one may not see any obvious macroscopic infarct. And what we look for histologically when we take sections of the myocardium, again, like with macroscopic features, the early features are very subtle. Over 12 hours, before 12 hours generally one sees nothing. There'll be edema with hemorrhage, really very little. What begins to happen at 24 hours, one gets coagulative necrosis of the myocytes. The myocytes swell up, become pink in colour, and the nuclei become small and what they call hyperchromatic. Pycnotic is the term used for them, which pathologists would be familiar with. It occurs 24 to 72 hours. And in association with the coagulative necrosis, you get an acute inflammatory infiltrate of polymorphonuclear leukocytes. So that is a very important feature we look for as one of the earliest signs of infarction, of death, irreversible death of the myocytes themselves. So it occurs 24 to 72 hours. Then with repair, after the initial insult death of the myocytes and the acute inflammatory reaction, macrophages and fibroblasts start migrating in. First of all, macrophages, often in association with plasma cells and lymphocytes, the chronic inflammatory cells, 3 to 7 days, with fibroblasts, collagen deposition going on after 7 days. A rough guide to, again, the aging of an infant microscopically. Now here's an example which I'll show of, again, coagulative necrosis. You can see these myocytes are swollen, and an important point is they lack nuclei. I can't see any. The normal myocyte nucleus is round and large. Here the nuclei have totally disappeared from these fibres, and you will see in the interstitial tissue between the myocytes lots and lots of polymorphonuclear leukocytes. So here, acute infarction with irreversible death of these myocytes, which will eventually be replaced by fibrous tissue. Now, an important point to look for, particularly when one gets reperfusion, which can, with thrombolytic therapy today, there's often early reperfusion of the infarcted area of the myocardium. And what happens with reperfusion is often myocytes which are just on the point of dying or reperfused. And what happens in these myocytes is the myofibrils within the myocytes themselves contract, and it results in the retention of the basic fuscin stain, and what you get is contraction band necrosis. You see these parallel bands here going perpendicular to the long axis of the myocyte, typical of reperfusion in infarct myocytes. And here we're on several days into the infarct. And what you see is these myocytes, which are highly irregular in outline and pink, they're being eaten into and digested. In other words, they're being broken down by macrophages. And in between here, you've got lots of very large cells, the macrophages, and also the small dark dots, which are the lymphocytes and plasma cells. So we're here into a cleaning up and mopping and repair operation, with these myocytes being digested and being replaced eventually by collagen. Now here's an example. I like this. Hopefully you're able to see it. It's again a transverse section of the right and left ventricle, and as I told you, in the context of reperfusion, this is infarcted area, again anterior infarct, showing deep hemorrhagic discoloration of the myocardium, and this is typical of when the dead myocardium has been reperfused quite shortly after the infarction itself. The infarction is irreversible, but here blood soaks into this area from the peripheral vessels. Often can occur with thrombolytic therapy when there's restoration of the lumen. And what you see in these reperfused areas, these are the myocytes here, some of which are dead, some of which will be alive, and in between you get actual lakes of red blood cells, so that the whole capillaries at the edge open up and flood the area with red blood cells. Hence the name infarction, or fill with blood, the myocardium itself. So typical of reperfusion. Now, what is the aftermath of infarction itself? First of all, with infarction, we get expansion of the infarct, and this is what has been seen obviously with increased imaging sophistication over the past 20-30 years with infarction. And what happens, you get acute infarct, which can be visualized as an area of dyskinesia or akinesia, but with time there is thinning of the wall seen, and that can occur quite soon after the initial infarct itself, days to weeks. So the thinning of the wall and the expansion of the wall itself. And with an expansion, we also may get extension of the infarcted area itself as well. In what context, how do you define this infarct expansion or extension? And usually by using the radius. The original radius here of the, let's say, left ventricular cavity, seen initially on imaging. With time, there is increase in one dimension of the radius, so there's one area that expands out, underlying the infarcted area. So it's an important prognostic indicator, because this area is less efficient, associated with left ventricular failure, cardiac failure, long-term prognosis of the patient. The larger the extent of expansion, the worse the prognosis. And what context do you see expansion? Well, the time course, as I say, is variable, occur to 1 to 14 days. It's usually, as you can expect, logically associated with transmural infarcts. It's also more liable to be seen with large anteroseptal infarcts. Quite frequent with the imaging, to see up to 50% almost of patients. And its association with obvious persistent occluded artery, and complications can occur. You're more liable to get rupture in these patients. You're obviously to get ventricular septal defects as well, and obviously aneurysm, which can develop either acutely or later, and you may get a minor or a major aneurysm. And as already mentioned, a chronic reduction in left ventricular function. What happens with the expansion? Well, it can be repaired by fibrosis, but we're going to be left with a fixed alteration in the left ventricular shape. Going on to immediate complications of myocardial infarction. Well, as I'm sure you're all aware of, the most common that occur is arrhythmia. And up to 80% of patients, when we get arrhythmia, is associated with the injured or dead myocardium. Not just in the area of the conduction tissue, but within the myocardium itself. And atrial tachycardias are very common, but it may range from those through to nodal rhythm, to ventricular tachycardias and ventricular fibrillation with sudden death of the patient. One may also get right and left bundle branch block. The right bundle branch block and left bundle branch block can progress to complete block and be prognostically significant. In addition, in association with particularly transmural infarcts, one may get left ventricular free wall rupture. And also, depending on the extent of infarction, cardiogenic shock will develop. And it often develops in association with an infarct that is greater than 40% of the volume of the left ventricle. Other complications include systemic emboli. This VHS should really be ventricular septal defect and papillary muscle rupture. All these are common with transmural infarcts. And as I said, the arrhythmic death, the most little ones are the ventricular arrhythmias. It's unrelated to infarct size. Even small infarcts can give you quite extensive arrhythmias. Common outside hospital and can be responsible for the sudden death syndrome. So arrhythmias, even before one develops histological evidence of infarction. These should be eminently treatable in the hospital scene. What about shock? As I said, it's related to infarct size, greater than 40% of the left ventricular volume. There's often superimposed diffuse necrosis in the subendocardium as well, in association with cardiogenic shock, related to generalized hypoperfusion. Now, rupture of the myocardium. You can get free wall rupture and you can get septal defects, and also following on aneurysms, which are all complications of transmural infarct. I'll show you examples of these. Now, what is rupture seen in? It's more frequent in females, elderly. No previous infarction in these patients, often associated with single vessel disease, with no functional. There may be collaterals present when you do angiography, but there may be no functional collaterals in these patients. So you've got more liable to have a transmural infarct with no previous fibrosis. And here's an example which I hope you can see here the outline of the left ventricle, here are the lungs on either side, and this is a massive hemipericardium that has occurred over an area of rupture. And here's a quick slide to show you the actual area of rupture. Look, this large area here. So associated. Now these occur peak at about 4 days, can occur any time afterwards. Obviously peaking at 4 days when the heart is at its most necrotic and soft and before the repair processes have been initiated. It is almost invariably fatal. And here's an example from history which I'll show you. And this is a report of the autopsy findings of George II, showing here a beautifully delineated, almost a bullet hole. This was before bullets were invented. So he died of the rupture of the myocardium, which was considered a great wonder at the time. Going on from there, from rupture of the free wall, which is common in the anterior wall or the lateral wall, we go on to another site of rupture, which is the ventricular septum. And here is an MRI scan showing a large ventricular septal defect occurring in the necrotic muscle. And here is functional, showing the blood flow across the septum itself. So imaging delineates these. Again, these patients can present catastrophic cardiac failure, shunting as one can imagine. And here's an example. Here on angiography, you'll see occlusion of vessel here. And here there is expansion of the infarct, nicely delineated. And looking up here is an area. this dark area, this is the interventricular septum, and here's the hole in that interventricular septum. Now another complication, as I've said, VSDs and rupture are quite rare complications occurring in 3 to 6% of patients. Papillary muscle rupture, which can occur with lateral and inferior and apical infarcts. Here is the mitral valve, and you can see this is the proximal end of a papillary muscle and a distal end here, pointing out the arrow. And there has been separation and rupture of the papillary muscle because of the infarction. A rare complication occurring in 1% of patients, and it results in fulminant mitral regurgitation, which can lead to death of the patient because the infarcted myocardium cannot cope with the amount of increased blood in the left ventricle. Now, going on from there to the more short-term, long-term complications of infarction associated with fibrosis and healing of the myocardium with cardiac failure, left ventricular aneurysm and thrombosis. Thrombosis can occur both early and late in myocardial infarction. And here's an example of a transplanted heart from St. George's, which shows what has been called ischemic cardiomyopathy, although we do not like to use the term cardiomyopathy for ischemic heart disease. What one sees is, look, well over 56% of the circumference of the left ventricle is fibrosed. It may be the result of one infarct or a superimposition of many other areas of infarction over time. You can see the thinning of the wall and the fibrosis, resulting in chronic cardiac failure, eventual transplantation of this. And in association with the myocardial fibrosis and thinning as seen here, one may get endocardial thickening, and also endocardial thickening which extends up to the papillary muscle. And one may get actual incompetence of the mitral valve long term because of papillary muscle involvement in the infarction and fibrosis. And here's an example of thrombosis. Here an apical infarct. You can see with thinning of the wall, anterior wall, apex. And here, if I can lighten it slightly, yes, you will see that the whole apex is occluded or occupied by adherent mural thrombus. Now these thrombi can embolize off in and on the left side into the systemic circulation to cause cerebral emboli, or into the spleen or kidney, or into the lower limbs as well. A rare complication, but established. In addition, we may get obvious pulmonary emboli as well due to deep vein thrombosis, because these patients, particularly previously, were treated with bed rest. So there's cardiac output, there is immobility of the patient, there's increased hypercoagulability. So when we get DVT, pulmonary emboli as well as systemic emboli. And finally, just a quick picture to show an aneurysm. You can contrast here, this is the anterior wall of the left ventricle, posterior wall, the normal thickness, and here you can see the thinning and ballooning out of the wall of the left ventricle with a fibrous band here. A chronic aneurysm which can develop within a short time and usually presents with untreatable or very difficult to treat cardiac failure. We see cases here which have been resected. So now I will go on from here to show you some examples of what we see about acute and chronic complications of infarction. I think I've got. First of all, what I'd like to show you, which you may see there in the audience, on this is a case I received last week, which was sent as a case of dilated cardiomyopathy. But what it actually shows, which you will see here on the surface, is a very hemorrhagic, thickened pericardium. And this is pericarditis, acute pericarditis, which occurs is a complication of myocardial infarction. You can see it's irregular, thickened, hemorrhagic. Now, pericarditis often presents in the first 48 hours of infarction. Usually has no prognostic association, but is seen as often with large areas of infarction. And you can get extensive hemorrhage into the pericardium itself. So that's the first point, and I will show you. That's the visceral pericardium, and here is the parietal pericardium, a small segment of that, which you will see. Here, again thickened, and again quite extensive hemorrhage onto this surface as well. And thinking about hemorrhage, one must remember the complication of Dressler syndrome, where one gets both pericarditis, pleurisy, and elevated ESR with pyrexia, which can occur several weeks after infarction, and has been linked to the degree of hemorrhage in the pericardium, and is also believed to have an immunological etiology. So the first thing to see here was the pericarditis. But looking at the transverse section here of your left ventricle, here the anterior wall, posterior wall, interventricular septum, right ventricle. The first thing to note is the very thin anterior wall, marked contrast to the lateral wall with normal thickness of approximately 12 to 15 millimeters. This is only about 2 to 3 millimeters in thickness. So the thing has been, this is an example of extension of the infarct. And you will see at the sides there's an area of hemorrhage here and this yellow discolored area. So it's necrotic myocardium. Going over, anterior wall is so thin one almost doesn't see any viable myocardium left at all. Here into the anterior ventricular septum, one sees a necrotic myocardium here, and again the hemorrhagic edge which delineates extent. This is an infarct that's approximately 4 to 7 days old. So a good example of attenuation and expansion of an acute infarct. In association with that, I may show you complication. I hope it'll be able to zoom in and see it. I don't know, I don't think it's here at the apex, but I don't think you can see it, I'm afraid. Yes, can. Little small, dark, hemorrhagic blobs. And these are actual thrombi that are overlying the apex. This is an anterior infarct extend to apex with overlying thrombi in the apex of the left ventricle. Complication of overlying damage to the endocardium. Now, going on to an example which I got from St. George's Hospital last week, I wish to show you here an example of again acute infarction. I'll return it here towards my side to orientate it. Again, we've left ventricular wall, which is again quite discolored and hemorrhagic. There's been acute attenuation here, it's quite thin compared to the posterior wall. So an acute infarct. But the important point is this is the septum here, interventricular septum, the aorta going up here. And in the interventricular septum, I'm able to insert my probe and I turn over into the right ventricle. And one can see there's actual perforation into the muscle of the right ventricle. So a ventricular septal defect resulted in death in this patient. She presented as a sudden adult death. And linking to this complication, I may show an example again of a ventricular septal defect. And I think this shows beautifully the extent, the ragged, irregular edge of the necrosis. A big hole has developed here, the interventricular septum. Through it again, I can quite easily pass my probe. Now, on occasion, patients can survive with ventricular septal defects. And when they do, what you get as a result, here is a very nice example. You will get rounding off and a reduction in the size of the ventricular septal defect itself. Again, all the defects will be in the muscular part of the interventricular septum because that's where the necrosis and infarction occurs. I'd also like to show you an example of a nitrotetrazolium blue transverse section which we've recently done. You have to use fresh myocardium for this. And again, it will delineate for you very nicely the viable remaining myocardium. And here in the anterior wall, this delineates scarring because this this will show scarring as well as acute infarction. So you see the acute infarct, or the old infarct I should say, at this stage in the anterior wall, interventricular septum, and going into the posterior wall. So this stain is very useful for giving you the extent of infarction. In association, one can also see thrombi at the apex, which is easily taken off in the apex of the left ventricle. And I think finally, I have an example to show you again of a long-term effect of infarction in association with fibrosis. And what one sees here is again the anterior wall with fibrosis and thinning of the wall. Here you've got papillary muscle, the chordae tendineae, going up to the anterior or the aortic cusp of the mitral valve. But you will see, hopefully, I'll just put it up slightly, look, this papillary muscle stretched. There is fibrosis around it as well in association with the area of infarction, and this stretching will result in a minor degree of incompetence of that mitral valve, which in a patient who's already got a compromised left ventricle may be obviously of poor prognosis for this patient. So in summary, I've discussed both the infarct itself and how we can actually assess it both microscopically and macroscopically. They have both acute complications, chronic complications. I think these are important because really myocardial infarct is the most common cause of death in the Western world. 160,000 cases in the UK alone. So for working pathologists, clinicians, extremely important entity to see, to delineate and to note its complications. Thank you.